Good morning, everybody. Welcome to Grand Rounds. It's my pleasure to introduce Dr. Vidang Nguyen today, who will be presenting. Vidang comes to us originally, she's a resident of Seattle mostly. She did her undergraduate work here and got 3 majors, and was also a Mary Gates Research Scholar. She then went to Tulane University, where I think she, maybe knowing or not knowing, got set up early with a future in cardiology, winning a DeBakey Research Scholar Award. She then did her residency here, and also been a fellow here. She's been extremely productive as a fellow. She's got 4 original publications, one in the Journal of the American College of Cardiology as first author. She also helped found the Women in ACC chapter here for women in cardiology. She's going to go on and do her training at Cedars-Sinai for her heart failure fellowship, and we're very happy to have placed her at such an excellent fellowship, and certainly more reflects her hard work than ours. So I'll let Vidang tell you about how to grow your transplant program in 2019. Please welcome Vidang.
All right, thank you for that introduction. So I'll kind of come on the heels of a couple of visiting professors here and just talk about how to grow your transplant program in 2019. I have no disclosures today. So my objectives for the talk today is to go over the importance of early referral for advanced heart failure therapy, talk about how to bridge your patients to heart transplantation, go over some of the impact of regional factors on your transplant program, as well as just review some things about donor selection and the consideration of new donor groups. So why is it important to always think about growing and building on your transplant program? Well, each year more people are being listed for heart transplant consideration. This is data that I pulled out from the UNOS registry showing the number of new candidate registration over time. You can see here, really since 2003, 2004, there's been a steady increase in the number of people added to the list each year. So let's take a look at what happened to these patients. Here I just broke down the ultimate outcome of each patient. You can see that fortunately most patients do receive the heart transplant. The yellow bars in the middle represent the patients who ultimately died. But if you look here, the proportion of patients who grew the most were actually those who continued to wait. And there's probably a couple of reasons for that. We have remarkable advances in our medical therapy during this time, as well as new developments in revascularization of patients with ischemic heart disease. We also have the implementation of ventricular assist devices to bridge patients to their final transplantation. The first generation HeartMate came out here in 2003, HeartMate 2 in 2008, and more recently we have moved on to the HeartMate 3 as well as the LVAD device. So why do these national trends matter to our patients? So I'll go over our case today of a patient close to myself. This is Gary. Gary's 54 years old. He has non-ischemic cardiomyopathy. His EF is 25%. Has been doing well for many years on guideline-directed medical therapy. However, lately he's not been doing so well. He's really had progressive dyspnea and exertion with NYHA class 3 symptoms, and he's been admitted 4 times this year with decompensated heart failure. He also had to stop lisinopril for intolerance. This brings me to the first objective for my talk today. Early referral for patients with advanced heart failure is very, very important. So why think about heart transplantation? Well, it really continues to be a gold standard for end-stage heart failure. This is from the most recent ICHLT report in 2018, where they really emphasize that the post-transplant survival has been improving with each iteration of their report here, showing that it still remains a very desired therapy for patients with advanced heart failure. Early referral is important. This is a study out of Sweden where they studied over 10,000 outpatients between 2000 and 2013. And they basically studied risk factors for decreasing mortality over time. They looked at hypertension, systolic blood pressure in the outpatient clinic, creatinine, hemoglobin, as well as medication intolerance. And they found that with each additional risk factor, there was a decrease in the 5 to 6 year mortality for these outpatients with NYHA class 3 or 4 symptoms, thereby suggesting that even with the presence of one risk factor, you should really consider an early referral for advanced heart failure therapy. But Gary is now an inpatient, so because we do so many of them here, he got a right heart cath and was found to be tachycardic. He has low blood pressure, high filling pressures, as well as a reduced cardiac index. So coming to our institution here, we do have an algorithm in place, as seen here, and this is from Occam. So let's figure out where he falls in this group. So I went ahead and calculated some of these numbers first. We determined that he might be in cardiogenic shock. So his CPI here, the cardiac power index, was 0.2, putting him in the group of having left ventricular instability. His PAPI is 1.2, which means that he just has primarily an LV dysfunction, indicating he'll probably need some sort of support, whether it's Impella or ECMO at this time. Tara Jones from last year presented some of this data and had the opportunity at this point to continue some of her work. So I took a look at the patient cohort here for that Shock 1000 registry. It's about 250 patients. And along with Davey McCabe, but then asked myself, well, what are the markers of high mortality in these patients here? I took a look at a couple of things. I evaluated the hemodynamic markers from a right heart cath, filling pressures, vital signs, labs, echoes, as well as the cardiac power that we use here, the cardiac power index, and also the shock index, which is a ratio of the heart rate over the systolic blood pressure on admission for these patients. So what did we find? Well, looking at all these markers, there were 3 things that were significant. The shock index, which is that ratio of heart rate over systolic blood pressure, the right atrial pressure, and the PAPI were the 3 markers that were significant in predicting 30-day mortality of all comers of shock at the University of Washington. Looking at the Kaplan-Meier curves for these markers for right atrial pressure and the shock index, you can see here that 30-day mortality is significantly lower in patients who present with a right atrial pressure greater than 16 millimeters of mercury. Same thing with the shock index. I found the max predictive ratio cutoff here is 1.24. So if the ratio of heart rate over systolic blood pressure is greater than 1.24, you also have an increased mortality. These Kaplan-Meier curves show this irrespective of the implemented therapies later on, such as inotropes or Impella, indicating that these are really good early markers for very severe heart failure. And we do propose that these could potentially be used for patients who do not present to our hospital, really prompting them to consider a transfer to a center that will be able to appropriately support the patient. So you're appropriately concerned about Gary. So when you talk to him about what he may need, well, he really wants to go camping, so asks if he can just come back after Memorial Day weekend. This is something that's not unheard of here at RCCU, I feel. So you think about this a little bit and see if you can wait. But then you also understand that sicker patients really have a worse survival after transplant. This is a very nice study out of Spain. They looked at over 700 patients between 2000 and 2009 and looked at all patients who were urgently transplanted for cardiogenic shock in the hospitals. They stratified patients by INOMAX profile, which reflect the degree of shock. As a reminder, INOMAX profile 1 are the crash and burn patients. INOMAX profile 2 are those who are sliding on support and on inotropes, whereas INOMAX 3 and 4 are those who are considered stable on inotropes or those who have resting symptoms. They found that with each INOMAX profile change, there was a significant increase in post-transplant mortality really showing that you should not wait until your patients are crashing and burning until you consider them for heart transplant, because even if they make it past that, there's a really high early mortality, almost 40% there before the first year is even over. So therefore, you don't feel comfortable discharging these patients, including Gary, back to home, and he does agree to proceed with some sort of therapy. So how do you get him there? How do you effectively bridge him to a heart transplantation? Well, let's move on. Whoops. There we go. There are many ways to do that. You can use inotropic therapy, such as dobutamine or milrinone. Use temporary mechanical circulatory support, or think about a more durable solution, such as LVADs, TH, and so forth. Before you put your patients on inotropes to go home, just think about that this is really not a long-term solution. Just waiting for, there we go. The University of Alabama just looked at a series of patients who were not considered transplant or LVAD candidates, and they looked at the long-term outcomes of the patient they discharged home on inotropes. And as you can see here, half of patients have passed away by 10 months. So without a destination in mind, such as transplant or LVAD, it's really not, again, a long-term solution, and it really should be considered a palliative measure if you're not considering them candidates. So what if they are candidates for therapy here? Most recent data really focused on the implementation of MCS as a bridge to transplant. So I just took a look at the more recent data for patients who were bridge to transplant on inotropes only. This is for the past 2 years, and I looked at the waitlist mortality over time waited for patients who were on inotropes only, those who are on any form of mechanical circulatory support, or those who are no support at all. And really, the patients who wait on just inotropes have a higher waitlist mortality, which is fairly consistent with patients who weren't candidates for anything really having a high early mortality within the first year. What I would take away from this is that inotropes are a reasonable bridge strategy if you have a program with an appropriate transplant rate or enough transplant volume to ensure that your patient can get to their final transplant in a timely manner for inotropes. Well, what are the other ways that you can do it? Well, the Impella device has become quite popular as a bridging technique. This is one of the early studies that described the Impella 5.0 as a bridge to a decision in patients who present with acutely decompensated heart failure. This was out of Tufts, Baylor, and University of Chicago, and over 5 years they identified 73 patients who came in decompensated heart failure, and they found that by using the Impella 5.0 device, they could bridge about 2/3 of their patients to the next therapy, whether that be full recovery, transplant, or LVAD. About 1/3 of these patients died. So it wasn't a full-on lifesaver there. They also described the complication rates that they had in their study. They had about 20% had some sort of infection with their device, and then 16% of these patients had a bleed requiring some sort of transfusion. Because we do so many of them here, you may wonder how we stack up to these people. Well, I did just create a database for our Impella use here at the University of Washington. So between 2016 and 2018, identified 117 Impella devices here at the University of Washington. This includes both Impella 5.0 and Impella CP. I excluded any device that was used just for procedure-related cause, such as protect PCI, structural heart cases. So all of these patients spent some amount of time in our CCU for ongoing support. So how did our patients do? Well, we actually have the majority of patients who had an Impella put in for shock ended up passing away, 43.6%. 40% of these patients recovered to home, whereas just a minority of these patients were actually bridged to another therapy such as transplant or LVAD. Comparing that to the multi-center data, our mortality rate's fairly higher, but we do have about 55% of patients who do recover or make it to the next therapy. I think this tells me that we see very, very sick patients here, and we, as one of the larger referral centers here in the state of Washington, we probably get more referrals than these other 3 centers combined, which are in major cities. But not only do we see very sick patients where majority of them don't, or a portion of them don't make it, we also see a lot of complications here. These are the complication rates for those 117 Impellas. We have a high rate of hemolysis here. 36% of these patients who end up getting Impellas end up requiring a transfusion for either severe hemolysis or bleeding. We have a high rate of arrhythmias here that are device-related, about 12%, requiring some sort of antiarrhythmic therapy. 3% of our patients had strokes with a device in, and then 7% had some other complication, which include things like limb ischemia. The complication is a time-dependent phenomenon. On the right here, I've graphed out the incidence of any complication as a function of time that the Impella has been in. You really see that by about 4 or 5 days, half of these patients have really experienced a complication. So I think next time you call for an Impella, just be cognizant of what your plan is for the patient, just knowing that it's not harmless just to leave the Impella in for an extra day. I think the role of the temporary mechanical circulatory support is unclear at this point. It's a topic of great interest, I think, to the greater heart failure and interventional community at this time. But I think in the select patient population, it can be an effective bridge therapy. So this is in contrast to the more durable mechanical circulatory support, such as the LVAD. The use the LVAD as a bridge to transplant has really increased over time. The report here from 2018 that I referenced before really shows that the patients who are bridged to transplantation on LVADs has increased over time, reaching about 50% in 2016. I also want to point out the other little data point is the sliver of dark blue represents the ECMO patient. That's been fairly stable over time, which is a very good thing, because if you look at the post-transplant survival of these patients, depending on their bridge therapy, you see that ECMO patients, as indicated by the red line, actually have a far worse post-transplant mortality. But we do also understand that these are sicker patients, and they often do not have any other options for support other than that. So I think understanding the ways to bridge your patient is one of the crucial factors of maintaining and growing your transplant program. So I think my conclusions from these bridge therapies that inotropes can be helpful, but it's highly dependent on your transplant volume and transplant rates. Temporary mechanical circulatory support are a reasonable solution in the short term, just being aware of the complications that can occur. And then durable support is really growing in use with increasing utility and shown efficacy. Gary gets an LVAD. He's very excited about that. And then, so how do we help him? What determines what will get him to transplant next here? Well, I think they'll go over some of the regional factors and implications for organ allocation for your patient. So what are the different factors here? There's a lot of regional variation in how transplant programs do across the country. There's competition between transplant centers for organs, which is a very limited resource. There are some very arbitrary allocation areas, and then there's the impact of ischemic time. This is a very nice abstract that came out last year. So this group looked at the perceived life years gained by transplantation in different areas of the country. So they compared regionally the expected waitless survival with anticipated kind of life gained by transplantation, and found that it's really not the same across the country, probably reflecting that the patients who are listed look very differently, the number of donors look very differently, and the expected post-transplant outcomes are very different. Fortunately, we're in the dark blue corner there, really having a lot of life gained here, just reflecting probably how well we do as a transplant program. The way that donors are used across the country are also very different. This is a heat map showing the proportion of hearts used of all of those considered available to your region in the different areas, where the green is being a higher proportion of hearts used and the red being less so. You'll see that the northeast corner and the southwest states really have a higher percentage of usage, whereas a state like Florida uses just about 25%. Really reflecting the variability in like an organ evaluation and organ utility as well. There's also a lot of competition between transplant centers. This is the first project I had the chance to work with Dardes on, and we looked at the competition index between centers. The Hirschman Index is a measure of market competition that's used within the finance world, where a lower HHI reflects higher competition. So we graphed that out on the graph on the left here, where 1 minus HHI reflects higher competition. And you really see there's a lot of variability across the 11 regions, with almost no competition in the middle of the country, with high competition in region 1, which is that northeast corner. And I do think competition really impacts the way a program behaves. It does lead to potential overtreatment. This group looked at in this study, they looked at the potential for overtreatment on the transplant list, where they looked at the documented hemodynamic markers of the patient and compared it to the implemented support therapy, whether it be inotrope doses or mechanical surgical support. And they identified certain areas that had some potential for overtreatment, and it does align fairly well with some of the regions with high competition as well. I'll briefly go over how organs are allocated and how that impacts what your region does for you. As most of you know, there's this different status allocations, but there's also the region in which you're in. The first area of allocation is the donor service area, noted here by DSA. And these are really arbitrarily defined areas which are considered your local area, and you have one organ procurement organization servicing that area. And then the next zone of allocation are concentric circles of 500 nautical miles moving outward, leading to zone A, zone B, zone C, and D. So for example, if a heart came up, you would first give it to a status 1 patient, which is the sickest patient in the DSA or zone A. Then you'd go to status 2 in the DSA or zone B, before coming back to the status 3 patient within the DSA. And that has been a change with the new transplant allocation system, and the goal has really been to transplant the sickest patients first at the expense of really incurring probably a higher ischemic time with broader regional sharing. But as I point out, these donor service areas are really not defined by, are very arbitrarily defined, and they're not all created equal. In this recent work that I did with Dardes, again, we looked at the hearts that are just allocated to the local region, so your donor service areas. But as you can see here, that's very different for centers across the country. And I think it particularly impacts us here at the University of Washington. So these local hearts for us, you can see, include hearts that come down from Anchorage. So it's actually not very local, and it does lead to a very high ischemic time for these organs that we get compared to a lot of these centers on the East Coast, which you can see have very short lines for patients, for organs that are considered from the local DSA. And we do have very long ischemic times. This is from the past 2 years, so 2016, 2017, and 18, showing where we've received our hearts from over these past 3 years. The darker lines mean that more hearts came from these areas, and you can see that we do get a fair number of our organs from Alaska. Median ischemic time is 3.7 hours, which is quite long, higher than the national average, with an interquartile range going up all the way up to 5.6 hours. So this is in contrast to Vanderbilt, which is well located, and they have a median ischemic time of 2.6 hours. And this other unnamed Southern California Transplant Center, which has a median ischemic time of 3.1 hours. So their next heart failure fellow can figure that out. So what is the role of geography? Well, regions have a significant variation. I do think it creates a lot of disparities in your allocation, how far your organs travel, and ischemic time. And I do worry that it promotes some sense of competition and gaming of the system as seen by people who may potentially overtreat their patient in the attempt to really get them higher on the list and to ensure that they get the organ over patients from other regions. For example, when we have hearts here from Oregon or somewhere, we do compete with California, which is a very densely populated area for some of these organs. So I do think it comes into play for us as well. Gary's listed here at the University of Washington. So how are we going to get him to transplant here, knowing that we have to deal with long ischemic times, a lot of competition as well? Well, there's been a lot of excitement about donor selection in the most recent years, and we'll go over some of these things. I'll go over kind of aggressive donor acceptance, the use of hepatitis C donors, and then just consideration of donors that are donated after circulatory death. This is from our paper from Jack, and I've simplified it a little bit for ease of understanding here. Here we looked at the perceived benefit of transplantation, looking at the hazard ratio on the y-axis of death of transplant compared over the death of a continued waiting, meaning that a lower hazard ratio means that you have you're likely to gain more from the transplant in terms of survival and mortality. I've grouped the patients by the recipient urgency status on the x-axis there. So status 1 is the sickest patient, followed by status 1B, and then status 2. And then the donor risk is the different color bars here, where the blue is the low-risk patient, donor, I should say, and then red is a high-risk donor. And you can see here that your status 1A patient, which is the sickest patient, have the most to gain from a transplant with both a low-risk donor and a high-risk donor, especially when compared to a less sick status 2 patient, even if that status 2 patient got a low-risk donor, and especially if that status 2 patient got a high-risk donor, which tells me that you should really be more aggressive about accepting organs for your sickest patients, and you shouldn't let the less ideal donors fall to your status 2 patients because they don't have a lot of gain, as their waitlist mortality is not as high as these high-urgency patients. I think we took some of this data to heart here at our institution, and our transplant group here did implement a systematic donor review selection process where I think each donor offer was critically reviewed just to see why we did or did not take this hard. And between 2 periods, the review process was implemented after period 1. They found that by being more thoughtful about it, they were able to accept more hearts that were ultimately transplanted, being less than half in period 1 to almost 2/3 here in period 2. And we've certainly seen the effects of this. This is data from the SRCR that I just pulled off yesterday, showing that these are transplant trends over the past 8 years here. We reached 87 in 2018. And then I think we're in our high 20s at this point as of this week. So in addition to a really more thoughtful donor selection process, there are other things that have affected our donor pool as well. And that's unfortunately been the epidemic of drug use. These New England Journal papers showed the number of donors that were retrieved from people who died from a drug intoxication. The map on the left here is 1999. The map on the right here is 2017. With the darker areas just showing that you're really increasing the number of hearts that you're getting from drug overdose-related deaths. Most of these hearts, other than being exposed to some high-risk behavior, are actually fairly good, as these patients don't have a lot of other comorbidities other than their bad behavior. But along with the intravenous drug use, you also have a high incidence of hepatitis C. And that's been one of the more exciting areas in the field in the past couple of years. The first center to really publish their experience with hepatitis C was Vanderbilt. And this was their, that first study here. They described their experience with 13 patients and where they transplanted hepatitis C positive hearts into Hep C negative recipients. 9 of these 13 patients seroconverted and then were treated until cure. What they show here is that after the patients were waiting, the waiting times are reflected by the red bar here prior to consent for Hep C transplantation. And after consent, they were then transplanted and had a shorter time period of waiting after consent, suggesting that if you're willing to take a hepatitis C heart, you may have a shorter wait time on the wait list and then could potentially reduce your wait list mortality by this point. This was followed up by the Donate HCV trial out of the Brigham, where they described 44 patients of both heart and lung transplantation. They implemented a protocol where they started treatment just 4 hours after the transplant and then continued the treatment for 4 weeks. 77% of their patients seroconverted with the Hep C positive heart into a Hep C negative recipient. And with this treatment protocol, they all had a sustained virological response even up to 16 weeks after treatment. And this tells me that even with the very effective treatment that we have for hepatitis C, it's really a way for us to utilize more hearts for these patients. We've done several here, and to my knowledge, they still are doing fairly well. The green patients at the bottom here just hadn't reached their full follow-up period time point just yet. Dr. Krish's group at Stanford then looked at all the potential donors that were hepatitis C positive and looked at all the recovered hearts that weren't used. So recovered donors are donors who had at least one organ used for other transplant, not including hearts. And then here it shows that hearts that were recovered are just a minority of that, and even less hearts are eventually transplanted. But it is increasing over time, and I think it's very encouraging and does reflect really a lot of potential to increase your donor pool over this time period. So I'll move on to the next point here, which is donation after circulatory death. So I'll just review really quickly donation after brain death, which is when a patient comes in with some sort of brain trauma or undetermined brain death, and if they are considered to have a normally functioning heart, we'll keep the patient alive with pressors, fluids, ventilation, while assessing the donor function and then assessing the recipient for that potential heart. If a recipient's selected and there's an appropriate match, you'll then take the patient to the OR, explant the heart, cool the heart, and then bring it to the recipient. But sometimes brain death does not come before full circulatory death. This is a schematic showing an example of a controlled situation where the patient is not expected to survive their condition but are not determined to be brain dead. So what the protocol here has been, and we don't do this in the US at this point, is that you determine that the treatment might be futile. The patient will start to drop the blood pressure and go into full asystole. Legally and ethically, in many countries, they've implemented a 5-minute period of no touch. So you have to make sure that there's no signs of life in this 5-minute period before determining that you can use that heart for potential transplant and then consent the family. This does lead to some amount of warm ischemic time, leading to some adverse effects on the organ, and could potentially affect your post-transplant outcomes. One of the first centers to do this was in the UK. There's a really long wait list in the United Kingdom. Less than half of patients are transplanted within 3 years of being listed over there. So they're really looking for ways to increase their donor pool. They published an experience of 28 patients using this normothermic regional perfusion protocol. So I'll just overview it really quick here. The patient goes into a systole. They will then, after that 5-minute no-touch period, they'll then cannulate the patient onto a VAV ECMO, place a swan, do a TE, assess the function of the heart, and see if it's appropriate for transplant. And then they'll explant the heart and then put it into this organ care system and then move it to the recipient. They found that there was no difference in the 1-year post-transplant mortality between DBD donors, which are the brain death donors, and the DCD donors as well. And they're very encouraged that this may be one way to really increase their donor pool. Their Australian experience has been similar. They used a direct procurement perfusion protocol where the patient will go into a systole, they'll wait for 5 minutes of no touch. The surgical team will be at bedside, and they'll actually bring the patient to the OR right away, do sternotomy, drain the heart, and then place the heart into this organ care system, a heart in a box here. And then they'll actually monitor the function of the heart, not with a Swan or TE, but by checking serial lactates, hemoglobins, and measure the aortic perfusion pressure, because they'll continue to perfuse it, and then transplant the heart. So they did this for 44 patients over there, and also found that there was no statistically significant difference between these two groups, but did note that patients who were bridged to transplantation on mechanical circulatory support were more sensitive to some of the adverse outcomes here. So hepatitis C donors and DCD donors are some rather exciting ways to potentially increase your transplant program and grow your donor pool. With that knowledge, Gary does agree to a hepatitis C positive heart. He gets transplanted and is very happy there. So what are my takeaway points from this talk? Well, I think early referral for advanced heart therapy is very, very important. Just be cognizant of the different ways that you can bridge your patient to a heart transplantation and understand when to implement the different methods for your patient population. Understand the regional factors on organ allocation and in your center in your region, and also be very thoughtful about donor selection and consider these new donor groups as well. I want to say thank you to the team of people who really helped me become the person I am today, and especially Todd Dardis, who's been really instrumental in my development and absolutely the #1 reason I decided to stay at the University of Washington. All right, thank you. Dr. Levy?
Very nice presentation. I was interested to see that the risk with inotropes over MCS is relatively modest, a couple % increased mortality at 1 year. Yeah. And you have the flip side that they're lower risk after transplant. So if you look at 1 year absolute survival of everyone, is it any different between inotrope support and MCS support?
On the wait list?
Well, if you had the wait list and then the post-operative, so you're looking at, are they alive at 1 year after they're transplanted? Does it end up being about the same because you have a little higher risk with anotropes before and a little lower risk afterwards?
I didn't run that analysis, but I would suspect that it probably would be about the same, because we do know that I had grouped all of MCS together in the waitlist mortality, so that includes both balloon pump, LVAD, or ECMO even. So I think that if you separate out some of these groups, you'll probably have the inotropes post-transplant survival is quite similar to some of the more stable VADs as well.
That was a great talk, thank you. Do you think anyone could investigate what the impact would be of, instead of flying organs, flying donors, both financial impact of that, whether families would be amenable to it, and just trying to find out what the overall impact of trying to move towards that direction. Todd told me that that's how it used to be done, but I'm just curious. I mean, it seems like you cut a ischemic time to 0.
Yeah. That's an interesting question. I'm not sure I haven't looked into that myself of flying donors to the recipient. I think ischemic time is tricky. I think up to about 4 hours, it's considered, the outcomes are considered fairly similar, lower than that. I think that if you are considering taking a heart that will have a longer ischemic time than that, then you have to be thoughtful about it. And I don't know if it's, we know how hard it is to fly patients down from Alaska in general. And if that's what we're going to start implementing, I think that our program may go under for other reasons. Yes.
Age of donor, have you looked at age of donors as being a significant?
Yeah, so older donors are associated with worse post-transplant outcomes. So that is a significant impact, or does it impact your outcomes as well, which is why I suspect that some of these hepatitis C donors are doing fairly well. Over time, donors that were considered hepatitis C positive are actually getting younger and younger. And I suspect that has a lot to do with why some of these patients end up doing fairly well, is that they have very young hearts. Dr. Roth?
Very nice talk. 2 questions.
Yes.
The first is, you talked about competition,
Yeah.
which in some contexts is a good thing, and so I wasn't quite sure how you were trying to frame it. Do you think competition between transplant programs is helpful or a problem? And the second question is, you showed a lot of metrics for performance across different aspects of advanced heart failure care. What's the right way to measure whether a heart failure program is doing well?
Thank you for that question. Competition is, I think, is a good thing. I think if people abide by the rules. I think with the new transplant allocation system, where we're starting to define more, the goal with the new system was to really be very clear about which patients belong in the higher urgency categories. So they, as most of us know, defined ECMO as status 1 and then moved some of the more disadvantaged groups up. But you can also treat your patients to a status, as we know. You can put the patient on inotropes, you can put a SWAN in, put the patient on ECMO if you went to that. So I think if we start to go down that road, which some areas may be, as shown by the overtreatment map there, and I think competition is a bad thing. In the competition study that we did, we showed that high competition actually promotes more aggressive organ acceptance by programs, leading to some decrease in waitlist mortality. So I think that if you know that if you don't take that hard, other people may take it from you. You may just be more aware of it and take it for your sickest patient. So I think in that way, it could be a good thing. In terms of how transplant programs are being measured, I think that's very difficult. There's a lot of, in addition to all the regional variations, there's also variations in how programs perform depending on things like transplant volume. Being the large referral center that we are here, we do take on higher risk patients as well, and I think a hot topic currently are the congenital patients who have a lot of in-organ dysfunction as well, and who should really take care of these patients. It should probably be someone like us. I'm working on a project with Dr. Krieger this time where we're looking at, well, which centers should be transplanting our congenital patients, and we probably find that centers with more surgical experience or congenital transplant experience do better with these patients. So to answer your question, I think that there should be some measure of what risk you take with your patient population and the patient selection, and that should affect how your program is measured against other programs, because that'll be different than a small program that just does 20 a year with very stable patients. Yes.
I'm interested about the international cooperation. We're near Canada. Are you competing with Canada in some way? I'm thinking about the Alaska patients. And the other question I have is this shock index. When do you measure that?
Thank you. I do believe I know that Canada sometimes comes up for some of the hearts that we have offered here, and I have to be honest, I'm not entirely familiar with how Canada plays into our organ allocation system. I don't know if it can come into.
We occasionally can get a heart from Canada, but it's very rare, maybe 1 or 2 a year.
And we occasionally give up a heart to Canada.
Yeah.
If nobody wants it. And so they don't compete with us, it's only if nobody else wants it that it will go to Canada.
And the shock index were all measured on patient arrival to the hospital. So their first set of vitals coming here. So it was regardless of what you end up doing eventually. Dr. Marr.
Really nice job. So I have a question and a comment. What hemolysis definition do you use for your statement?
We use the definition of hemolysis as the clinical description of hemolysis with a drop in hematocrit and requirement of a transfusion is what we ended up using. So it was a very clinical definition more so than a direct laboratory one.
Did you use LVAD or?
We looked at LVH, they were elevated in all of these patients, yes.
Because I think the more probably helpful definition is plasma-free hemoglobin, which is the contemporary way to approach hemolysis in short-term devices. My comment is it's difficult to interpret the short-term device outcomes if they're taken out of the context of indication and patient selection. Because our outcomes are very different if we institute short-term devices proactively versus reactively in patients who are essentially in extremis, and also as a bridge to nothing. If they're not a candidate for advanced heart failure therapies, there's a lot of patients who still end up with devices as desperation therapy, but essentially a bridge to nowhere.
Yeah.
And I think that's the sort of cautionary statement when you take all of that data in aggregate. Because the complication rate and the survival is very different if you look at patients who have the option of a next step and MCS happens proactively versus you do it because the patient's crashing, they have a blood pressure of 30 and some kind of procedural complication.
I agree with you, and I think that's been the major challenges in the study of temporary mechanical circulatory support on a national and even international level. I think at the most recent meeting at the ICHLC in Orlando, when people presented their shock or MCS data, I think we ran into the same issues where it's really difficult to stratify the patients by what their caring provider at the time anticipated for the patient, and it was difficult to control for that, and I think that'll be the major thing that limits a good shock trial going forward, unfortunately.
April?
It's a really nice talk today. I just want to address Greg's question so that everyone knows that UNOS hires a statistical organization called the SRTR. Todd knows what it stands for. That follows every single organ transplant in the country for the first year post-transplant for outcomes. And outcomes are adjusted on an expected to observe ratio based on risk factors of the donor and the recipient. And there's a crazy statistical process in which they determine if a program is becoming close to a bad outcome, and at which point they're flagged. And once they're flagged, they have to fill out a whole bunch of forms explaining what they're doing to look at this, why this is happening, and they go to a national committee that then tracks if that program needs to be monitored and needs to do additional work to improve their outcomes. So it's actually, from a quality assurance standpoint, probably to my eye, the most impressive quality assurance that occurs in anything in medicine today. But it does take into a lot of accounts, and it's not perfect by any stretch. I mean, programs get flagged that should be flagged, and programs that should be flagged aren't flagged, but it's the best we can do now, and I think it shows the country that there's stewardship over the organs to continue to get people to donate, because the core of getting more transplants is to get people to be donors.
So that was a great talk. Sort of to follow up on that, you mentioned the issue of gaming the system, and that's actually been going on forever. There were some other unnamed Southern California hospitals who are actively caught in the act. But I guess my question would be, knowing that this happens and we do this all the time, and whether or not it's good in terms of competition, is there any police organization that's looking into that? Because it really does, especially with the interconnectedness of the regions, affect the fairness of the entire system, potentially, therefore, if it hits the front page, leading to a reduction in donation.
Yeah.
Well, if you're reported, so sometimes people within programs will report there'll be anonymous reports come to UNOS with somebody gaming the system.
So that's the only way that you would know.
Yeah, and I think that the JACC publication that showed potential overtreatment was an attempt at shaming some regions into thinking about what they're doing to that effect. Carmen?
Should we be transporting all our donation after brain death organs within the organ care system as well, rather than cold ischemic?
Okay, but the trial, there was a trial on that to see what the outcomes were, and I have to admit I forgot what they ultimately showed.
The results are similar
Yeah.
to standard preservation,
Okay.
but the idea is obviously you can take a heart from much further away and get maybe the same results.
Yeah. All right, thank you.